Welcome to today's iReview session. My name is Yejun Hong, a second-year medical student at the University of Calgary. Our team here will present to you today the ophthalmic changes in schizophrenia as a link between ophthalmology and psychiatry. The two links between schizophrenia and the eyes that will be explored in this presentation is first the abnormal eye movements, and second the retinal abnormalities, or also known as retinopathies. In abnormal eye movements, there are different levels of eye movements that can go wrong, from reflexic eye movements to conscious control from the brain that moves the eye in an organized fashion to take in visual information. So more specifically, some of the examples we will explore is the impaired smooth eye pursuit movements and the limited exploratory eye movements. In terms of retinopathies, there are three solid findings in literature. First is the wider retinal venules for those with psychosis, and the thinning of a layer called retinal neural fiber layer, as well as reduction in the macular volume and area. And lastly, the increased perception of brightness and color intensity. This, in turn, also decreases contrast sensitivity. So before we delve further into making this connection between schizophrenia and the eyes, it's important, I think, to know what schizophrenia is. So schizophrenia is a psychiatric disease with psychosis that significantly impacts an individual's function. And while schizophrenia as a word means the splitting of the mind, schizophrenia does not mean a splitting of personality. Rather, schizophrenia describes an array of psychosis-related symptoms and behaviors. Schizophrenia is also a syndrome associated with many different symptoms associated with that, and it also has individual variations. And the symptoms are, as seen in these two pictures, classified into positive symptoms, negative symptoms, as well as cognitive ones, and we will explore this more in the next few slides. So there is a very important manual that psychiatrists often refer to, and this is called DSM-5, or the Diagnostic and Statistical Manual, the 5th edition. And this describes schizophrenia as a syndrome with two or more of the following 5 symptoms: delusion, hallucinations, disorganized speech, grossly disorganized or catatonic behavior, and negative symptoms. And one important point is that at least one of the symptoms that the patient is experiencing has to be one of the 3 bolded bullet points: delusions, hallucinations, and disorganized speech. Delusion is a firm belief in a concept or an idea, despite any evidence that might be to the contrary. So for example, the FM radio is a message transmitted by aliens. That could be one example of a delusion. Hallucination is a sensory perception, despite the source of the perception not being existent. So we have 5 senses, and the most common for schizophrenia is an auditory hallucination, where you hear noises or someone whispering or talking to you, despite there not being any sound in reality. There can also be visual hallucinations, where the patient see things. And there are also haptic or somatic hallucinations, where they might feel something on their skin or even inside. For example, they have a belief that someone implanted something in their brain, and they feel it. Last two, the gustatory or the taste sensation, and the olfactory hallucinations. These are rare. The catatonic and the negative symptoms are the last two. Catatonic behavior is divided into, there are 3 catatonic behaviors, including akinetic mutism, catatonic posturing, and wavy flexibility. In terms of negative symptoms, we have affective flattening, alogia, and avolition, and we will cover these in the next few. So the fourth symptom, the catatonic behavior, is a series of symptoms that involves lack of movement or communication overall. And we will describe three of these. The first is akinetic mutism, and this is exactly how it's described. Akinetic means no movement. Mutism means mute, lack of speech. And patient will experience both of these. Catatonic posturing refers to a very rigid and immobile postures, and we have this helpful GIF to illustrate that. See how the patient is very rigid, and he's also in seemingly uncomfortable position as well. And the GIF also demonstrates waxy flexibility. So it seems like he's moving or encased in a liquid of wax. Right? The movement is slow, despite having initiated movement, albeit by the examiner. So the definition of this is the tendency to remain immobile in any posture, just like a wax has been encased over the joint and the muscles. So upon the stimulus, and there is significant resistance, and as the muscles slowly release and the limbs start moving very slowly. And finally, we have negative symptoms, which are deficit symptoms. And these involve minimal expression or interest in things around them. And these deficits can range from affective deficits, affective flattening that I've mentioned before. And this refers to patient having minimal facial expression, and anhedonia, which is a lack of interest in any activities, blunted affect, which is the diminished affect we talked about, and poverty of speech or allosia that was mentioned earlier. They are lacking in the amount of speech when communicating with someone else. And one more thing to add is avolition. This is when the patient has no motivation whatsoever to initiate something, to perhaps improve or enjoy an activity, even their hobbies. So that was criteria A for schizophrenia. There are many other criteria to determine if the patient has schizophrenia. Part B is whether a patient has one or more social or occupational functions that are significantly impaired. This includes the aspect of work, whether the patient is working as efficiently as before, hobbies, relaxation, if the patient is able to enjoy and relax as much as he or she would have liked, as well as maintaining relationships. This is referring to whether the patient can effectively maintain and nourish the interpersonal relationships. And C is duration. So at least 1 month of class A symptoms that we talked about earlier, but that's not enough. In total, 6 months of these symptoms needs to be continuously observed for the patient to be diagnosed with schizophrenia. And if you look at the picture here, 1 month in total would just be a brief psychotic disorder. Between 1 and 6 months is called schizophreniform disorder, and more than 6 is schizophrenia. And these are just how the diseases are classified. So the pharmacological treatment to schizophrenia is antipsychotics. There are two types of antipsychotics, typical and atypical. Atypical antipsychotics like olanzapine, risperidone, they block dopamine D2 receptors as well as 5-HT or serotonin receptors. The typical ones, like haloperidol, only block D2 dopamine receptors. Typical antipsychotic drugs are recognized as first-generation antipsychotic drugs, while atypical ones are second because they're newer. But they are also more expensive, although they have less severe side effect profiles. On the other hand, typical antipsychotic drugs are more affordable, but has more side effects, and are more likely to cause extrapyramidal motor control disabilities. Now that we have learned about schizophrenia, let's turn back to the eye. Most of the ophthalmic conditions in schizophrenia occurs on the retina. So it is important to understand the anatomy of the retina to understand how the conditions present. To give a little bit of a context, the retina is the innermost layer of the eye, the outermost being the sclera, and the middle layer being the uvea. The anterior uvea consists of the iris and the ciliary muscles, and the posterior uvea, the choroid layer. When looking at the retina through a fundoscopy, you would be able to identify some of the important structures. The fovea and the macula lies on the temporal side of the retina. That would be observed as you move more nasally or in the opposite direction from the patient's point of view, because on a fundoscopy, everything is flipped. The fovea and the macula contain the highest concentration of cones, and this is where your central vision is perceived. The optic disc is in the opposite side, or on the nasal retina, and this is where all the ganglion cell axons throughout the retinal layer collects for the exit from the eye. These collection of axons eventually become the second cranial nerve, or the optic nerve. Because it is a collection of the axons, there are no photoreceptors in this region, and therefore the optic disc is also known as a blind spot. You cannot see any or perceive any light that converges on this blind spot. On the retina are also vessels. There are both veins and arteries that can be visualized with fundoscopy. And this vasculature supplies the retinal layers with nutrients and oxygen. Within the retinal layer, there are also multiple sublayers that help either supply nutrients or participate in an intricate system to detect light and interpret it into an electrical signal. I have organized the general sublayers of the retina from the innermost to the outermost and eventually the choroid in this slide. And this is a more visual illustration of the layers that were stated in the last slide. And so you see the bipolar layer, the horizontal cells, photoreceptors, the retinal pigment epithelium, as well as the Brooks membrane that divide that acts as a border between the choroid and the retina. And with the eye overall, the light first passes through the cornea and the anterior chamber. The iris can constrict or dilate to control the amount of light entering the eye. The light then passes through a clear lens, which then goes through the vitreous before hitting a specific part of the retina. So now that we've learned some of the anatomy of the eye, let's dive back into how schizophrenia is related to some of the eye abnormalities. So we should note at this point that schizophrenia is a hyperdopaminergic state. In contrast, Parkinson's disease is a disease that lacks dopamine. So they are opposites, which means sometimes when you're treating schizophrenia by depleting some of the dopamine production, this can cause some Parkinsonian symptoms and vice versa. And when there is a high level of dopamine, there are four dopamine-specific pathways in the brain. In schizophrenia, the mesolimbic pathway is elevated, saturated with dopamine, and causes positive symptoms. In contrast, the mesocortical pathway observes a dopamine hypoactivity, and this causes negative and cognitive and affective symptoms. Some of the drugs can cause the other systems to go activate too much, and some of the typical antipsychotics actually can overactivate the nigrostriatal and the tuberal hypophyseal pathways. So although in the mesocortical pathway dopamine is hypoactive, overall in the system there's an elevated level of dopamine, and high dopamine in the brain means high dopamine in the retina, because they're very close and linked with the optic nerve. High dopamine in the retinal D2 receptors, especially in the cones, this causes hyper-intense perception of color. This in turn means that the patient will experience difficulty sensing contrast. So contrast, if you look at the picture right below that bullet point, you'll see a white background with black letters, right? And contrast is simply our ability to distinguish that difference in the shading. Some of the schizophrenic patients and others with impaired contrast sensitivity might have more difficulty than others to read some of the letters in the lower lines. We have already discussed that in schizophrenia, the macular volume and the macular area diminishes. And because the macula and the fovea are responsible for central vision, this atrophying causes diminished visual acuity. And in just the previous slide, we discussed that schizophrenia with that excess level of dopamine can cause decreased contrast sensitivity. Now it's time to talk about the movements of the eyes. And take a look at this picture here. The series of pinkish purplish dots are indicating what the participants see at any given time. So in healthy participants, when they were given a new picture or a scenery, their eyes move all over the picture. They try to see everything. It's exploratory. But in comparison, participants with schizophrenia, their eyes tend to gaze at a very localized fashion. Their exploratory eye movements, in other words, is very limited. And not only that, while looking at this scenery, when there was a visual pursuit, when there was a moving object, there was a little difficulty in maintaining that visual pursuit. The eye could not track the object that was moving, and because it kept slowing down, but the brain orders the eye to keep up to that target, the eye adjusts with the rapid late saccade to catch up to the moving object in focus. So these are some of the eye movement abnormalities that could be very interesting for future research. Now, one sign that you can observe in the eye with the schizophrenic patient, demonstrated by several studies, is widened retinal venules. So when you're looking at the back of the eye with a fundoscope, you will see that there are these vessels spread across the retina, like in this picture. But they are not blue and red. They're all very reddish. And the one way to distinguish between venules and arterioles are by is by the width. Venules are generally wider than the arterioles. But what I mean by widened retinal venules is that the discrepancy of the width between the venule and the arterioles are exaggerated in those with schizophrenia. So they will look abnormally larger and wider. So what I've described so far, the symptoms and signs of retinopathy and eye movement abnormalities, sound very qualitative, shall we say. You're probably wondering if there are ways to quantify these findings, and there are some investigations that can be done in terms of retinopathy. We'll introduce the OCT and the ERG. First, the OCT is optical coherence tomography, and this is a non-invasive imaging modality that uses light waves to take cross sections of the retina. This is great for measuring the thickness of the retinal layers, and actually, if you remember how I mentioned the RNFL is thinned in those with schizophrenia, well, you can observe that here. In ERG is electroretinography. This is a method where an electrode is attached at the cornea. This electrode detects the electric signals from the photoreceptors at the retina. Any abnormal signs would indicate problems in the retinal layer. And also in schizophrenia, the ERG tends to demonstrate a diminished rod B wave amplitude and longer latency. The treatment for schizophrenia-induced retinopathy is treating the underlying cause. And to treat that underlying psychosis, we use antipsychotics, which are found to have diminishing effects on the ophthalmic symptoms as well as schizophrenia. However, we should always keep in mind some of the effects of some psychiatric medications on the eye. We will specifically cover two medications of antipsychotics and also give the general side effects. First, thioridazine is a first-generation antipsychotic which has been withdrawn from the market in 2005 because of severe cardiac arrhythmia that it can cause. Thioridazine can also have adverse effects on the eye, such as decreased vision and dyschromatopsia, and eventually it can also lead to pigmentary retinopathy as well, which we will cover in this slide. Secondly, chlorpromazine is another antipsychotic, and it can cause cataractous changes in the lens, although this is quite rare. Generally, antipsychotics can also cause transient blurred vision, transient dilation of the pupils called mydriasis, blepharospasm, which is a term for eyelid muscle spasms, and pigmentary retinopathy. This is a pathology with pigmentary spots, dark spots all over the retina, and it can lead to degenerative retinopathy. The prognosis of schizophrenia-induced eye abnormalities are unfortunately not well studied. One of the factors that contribute to the uncertainty is because the patients with schizophrenia do not routinely obtain ocular exams. Nevertheless, it is known that schizophrenia is not a curable disease, so this is something that needs to be constantly monitored. And when symptoms arise with these psychiatric conditions, managing them appropriately is important for the patient's quality of life and their ophthalmic health as well. Regular eye checkups with ophthalmologists is also important. We have covered a lot in this presentation, but the main message is to establish a link and inform of this link between schizophrenia and the eyes. In summary, There are two main categories: abnormal eye movements, where there are also impaired smooth pursuits and limited exploratory eye movements. And second, retinopathies, so wider retinal venules, RNFL thinning, and also reduction in macular volume. Lastly, increased perception of brightness and color intensity, which leads to decreased contrast sensitivity. There are also studies that found correlations between schizophrenia and other eye diseases. And this has not been extensively studied either, but schizophrenia is associated with lens opacities and cataracts. And in the front of the eye, there can be pigmentation in the cornea. And the second point is the relations with strabismus. Children with strabismus, which is a misalignment of the eyes, they can develop schizophrenia later. And also those with schizophrenia are also at a higher risk of developing strabismus. Overall, the link between the eyes and schizophrenia is quite promising. When the research becomes more extensive and we get to characterize these general findings more and more, this might be a way to detect and diagnose and treat earlier some of the psychiatric disease, including schizophrenia. There is a saying there is an expression that says the eye is a window to the soul, and that might be quite literal if you look at the series of studies. So specifically, ophthalmic findings can be used as biomarkers. The unique eye movements, the diminished visual acuity while other sensory functions are intact, widened retinal venules, of course, thinning of the RNFL, and abnormal ERG waveforms, among others. These are quite a characteristic finding according to the studies, and they can be characterized in a more specific manner in the future. This is a summary chart of everything we talked about in this presentation. I hope you find this helpful. And lastly, here is the reference of all the resources that we've used to put this presentation together. Thank you for watching.